Arterial disorders. Arteries characterized by presence of collateral circulation, which is normally collapsed. Circulation opens whenever the blood's flow in the main artery is inadequate for the tissue requirements. Arterial ischemia. Definition: arterial supply is not enough to meet the tissue requirements. Types: acute or chronic, according to the speed of arterial flow reduction. Etiology: according to the type of artery, rate of occlusion of the artery, state of collateral vessels, and general condition of the patient. Type of artery: subclavian artery, very efficient collateral circulation, while the popliteal artery, poor collateral circulation. Rate of occlusion of the artery: acute ischemia is much more serious than chronic ischemia, as there is no enough time for collateral circulation to open. State of collateral vessels: healthy collateral vessels can compensate to some extent the ill effects of ischemia. General condition of the patient: presence of myocardial insufficiency or severe anemia exacerbate the effects of ischemia. Vascular laboratory: Doppler ultrasound, non-invasive, painless, portable, and inexpensive. CTA, computed tomographic angiography, done by injecting iodine-rich contrast materials through an arm vein, not an artery, and so it's less invasive than catheter angiography. Urea and creatinine estimated because the contrast material is nephrotoxic. Magnetic resonance angiography, MRA, visualizes blood vessels without injection of any contrast. Digital subtraction arteriography, DSA, allows visualization of arterial tree without arterial cannulation to avoid its possible side effects. X-ray picture is taken and image is introduced to the computer. Direct arteriography, invasive, only performed in need for endovascular procedures. Direct femoral arteriography and transfemoral aortography. Direct femoral arteriography, direct puncture of the artery is done and injection of contrast material will allow visualization of the whole arterial tree. This technique is losing in favor of the more informative aortography, popularity nowadays. Transfemoral aortography, cannula is introduced into the femoral artery, the pulse is felt on this side, then a guide wire is introduced, then needle is removed, and then a long catheter is introduced along the guide wire till it reaches the desired level and the contrast material is injected. Transaxillary aortography is done in included whole distal aorta. Translumbar aortography by direct aorta puncture is no longer done. Acute limb ischemia. Definition: sudden interruption of the flow to a limb leading to limb loss or death. Etiology: arterial embolism, acute arterial thrombosis, arterial trauma, aortic dissection, external compression by tight tourniquet, compartment syndrome, extensive iliofemoral DVT. Sites: we have common femoral artery bifurcation, 40%, aortic bifurcation, saddle embolus, popliteal artery bifurcation, brachial artery bifurcation, and common carotid artery bifurcation. Arterial embolism. Definition: embolus is originally Greek word which means plug or stopper. Embolism is the passage of a matter from one part of the circulation to the other through vascular lumen. Sources: cardiac emboli and non-cardiac emboli. Cardiac emboli about 80 to 90% of the cases, secondary to AF, myocardial infarction, left ventricular aneurysm, endocarditis on top of rheumatic or congenital heart diseases. Atrial fibrillation is the commonest cause, as it commonly results in stasis and formation of left atrial thrombus. Myocardial infarction leads to formation of neural thrombosis. Non-cardiac emboli about 20% of the cases, extensive atherosclerotic lesions or aneurysms of major arteries such as aortic arch and descending aorta. Sensitivity of various tissues to ischemia is variable according to the sensory nerves responsible for light, touch, and proprioception are very sensitive, followed by fibers for pain, temperature, and pressure. Motor nerves lead to muscle weakness, skin at first pale, then dusky blue due to capillary vasodilatation, lately extravasation of blood due to capillary disintegration, skin isn't viable. Acute arterial thrombosis. Etiology: atherosclerotic obstruction, pump failure, hypercoagulable state, febrile illness, acute graft thrombosis, and inadvertent intraarterial injection. Atherosclerotic obstruction, acute thrombotic occlusion on top of atherosclerotic narrowing is the commonest cause. Pump failure, sudden decrease in cardiac output, leads to acute limb ischemia in patients with extensive atherosclerotic peripheral vascular diseases, hypercoagulable states, usually in small arteries, febrile illness or gastroenteritis, especially in children, may lead to hemoconcentration with subsequent thrombosis. Acute graft thrombosis may occur early due to technical factor or late due to progression of original disease. Inadvertent intraarterial injection, which may occur in adults, causing intensive vasospasm followed by thrombosis. Pathophysiology, propagation of thrombus, associated venous thrombosis, compartment syndrome, and then we have finally systemic and metabolic sequelae. For propagation of thrombus after circulatory arrest, widespread distal intravascular thrombosis occurs, collateral circulation also markedly impaired, associated venous thrombosis due to combination of sluggish flow and ischemic injury to the anthema and involved of the involved veins. Compartment syndrome, ischemic muscles get swollen, which in turn exaggerates the effects of ischemia. After revascularization, more edema of muscles occur, more circulatory interruption can be avoided by early fasciotomy. It occurs in flexors more than extensors and in deep flexors more than superficial flexors. Systemic and metabolic sequelae. Muscle ischemia leads to rhabdomyolysis with liberation of potassium, lactic acid, and myoglobin. The sudden release of these metabolites into the systemic circulation leads to reperfusion syndrome, characterized by metabolic acidosis, hyperkalemia, and myoglobinuria. Myoglobinuria and acid urine lead to acute renal failure. Clinical picture, we have 6 P's: pain, paresthesia, paralysis, pallor, pulselessness, and poikilothermia, coldness. Pain, usually the first symptom. Paresthesia, paralysis due to ischemic myopathy more than nerve, hypoperfusion. Then function of intrinsic muscles of the foot is lost first. If ischemia continues, patients develop cuff tenderness due to swelling of gastrocnemius and soleus muscles, indicating muscle infarction. Signs: pallor, the color of skin is white with absent capillary refill. Veins recollapsed and there's venous guttering. The leg may even appear cadaveric. Fixed mottling and fixed cyanotic or purple areas of the skin which fail to blanch on pressing. Pulselessness is the absolute prerequisite to acute ischemia, poikilothermia, or coldness. Then we have comparison between embolic and thrombotic causes for ischemia. For embolic, history, arrhythmia, source of emboli present, radial pulse irregular, atrial fibrillation, skin color white, limb nutrition normal, angiography, sharp cut off. Collaterals we have minimal. But for thrombotic causes, history, claudication, source of emboli absent, radial pulse regular, skin color dusky, limb nutrition, picture of chronic ischemia, angiography, tapering stenosis, collaterals extensive. Investigations, imaging, Doppler scan localizes and identifies embolism or thrombosis. Arteriography may cause delay of 2 to 3 hours not done in threatened limb. CT angiography or transfemoral arteriography are better. In embolism, proximal arteries are normal and there's abrupt occlusion, classic meniscus sign, no collateral arteries. In acute thrombosis, proximal arteries are unhealthy and there is extensive collateral circulation. Angiography will show the distal runoff. Echocardiography detects cardiac sources of embolism. The transesophageal route is 4 times more informative than the transthoracic. CBC, raised hemoglobin, blood urea, nitrogen, creatinine indicates intravascular hypovolemia due to fluid sequestration in limb. ABG, acidosis and raised creatinine, phosphokinase, and YBCs indicate extensive muscle necrosis. Limb viability. Viable, no sensory loss or muscle weakness with audible arterial and venous Doppler signals. Immediate threatened, we have sensory loss marked with rest, pain, moderate muscle weakness, usually inaudible arterial Doppler signs, and audible venous Doppler signs. It's salvageable and immediate revascularization. Irreversible, profound sensory loss, profound muscle weakness, or paralysis, and inaudible arterial or venous Doppler signals. This stage is non-salvageable. And then we have the general measures in treatment: controlling arrhythmia or heart failure and cardiac monitoring, correction of dehydration, controlling pain, oxygen administration, and immediate hyperonization. It prevents proximal and distal thrombus formation. Start with loading dose of unfractionated heparin, 80 international unit per kilogram, followed by maintenance dose, 18 international unit per kilogram per hour. The dose is controlled by checking APTT every 12 hours, which should be maintained 2.5 to 3 times the baseline level. Embolic acute ischemia requires urgent surgery. Acute thrombosis may produce less severe ischemia because previous chronic ischemia opens collaterals. For embolism, urgent embolectomy using Fogarty balloon catheter is a standard method for removal of arterial emboli. The operation should be done as long as the limb is viable, as delay leads to obstruction of collaterals by propagation of thrombosis. Operation can be done under local or general or epidural anesthesia. Femoral artery embolectomy done via common femoral transverse arteriotomy. Aortic bifurcation embolectomy is done by bilateral femoral arteriotomies. Brachial artery embolectomy done by brachial artery exposure. Arteriography done on table to confirm clearance of arterial tree. Heparin should be continued post-operatively until cardiac condition is assessed and need for more heparin therapy is determined. And then we have fasciotomy. Embolectomy is followed by compartment syndrome, therefore it should be decompressed by full-length skin and facial incisions from the knee to the ankle. The source of arterial emboli should be corrected. Acute thrombosis, severe ischemia, urgent arteriography is performed to plan for emergency revascularization surgery. Moderate ischemia, urgent arteriography is performed. There's time for the use of thrombolytic therapy after thrombus dissolution. Elective revascularization surgery. Elective surgery carries better prognosis than emergency surgery. Arterial injuries, etiology, penetrating trauma, blunt trauma, and intra-arterial drug injection or iatrogenic. Penetrating trauma, low-velocity agents such as knives damage structures in their pathway. High-velocity missiles, widespread damage can affect remote vessel. Closed-range shotgun, widespread damage which penetrates tissue. Blunt trauma, a road traffic accident, direct injury to major vessels, fractures and dislocations, supracondylar fractures of humerus. Intra-arterial drug injection, iatrogenic, pelvic operations, arterial cannulation in arteriography. Types, we have 3 types: arterial tear, arterial spasm, and arterial contusion in thrombosis. Arterial tear, complete tear and partial tear. Complete tear, transection, transected ends retract, constrict, and thrombose, leading to ischemia rather than hemorrhage. Partial tear, the coats retract, leading to widening of the gap, presenting with hemorrhage if bleeding remain within the tissues, pulsating hematomas, traumatic falls aneurysm, pseudoaneurysm. If bleeding finds its way to the exterior, it leads to life-threatening hemorrhage. Concomitant injury to adjacent arteries and veins lead to AV fistula. Arterial contusion and thrombosis, commonest type in close injuries, presents with ischemia and thrombosis, occurs over damaged area. Arterial spasm, associated with ischemia and diagnosed after exploration to exclude contusion and thrombosis. Clinical picture, heart signs, sure signs of arterial injury, external arterial bleeding, loss of distal pulses. Classical manifestations of acute ischemia, the 6 P's: pulsating or expanding hematoma, palpable thrill, or audible bruit. Soft signs, they are less specific signs: adjacent nerve injury leading to neurological deficit, proximity of penetrating wounds to major vascular structure, moderate-sized hematoma not pulsating and not expanding, diminished pulse compared to the contralateral side, history of pre-hospital hemorrhage which has stopped, or presentation with shock which cannot be explained by other injuries. And then we have investigations. No need in hard signs. Immediate surgical exploration is life-saving. In patients with soft signs, urgent investigations are needed. Plain X-ray to detect foreign bodies or fractures. Arteriography only for patients with either abnormal upper extremity pulse, examination, or Doppler index less than 1. CT angiography for arterial injury and adjacent structures. Treatment, immediate treatment, and definitive treatment. Immediate treatment, control of external bleeding, resuscitation, heparinization, prophylactic antibiotics. Controlling external bleeding, Direct local compression at the site of the injury is the most effective method at the scene of accident or in the emergency room. Blind placement of clamps into bleeding wounds should be avoided. Tourniquets should be avoided since they can occlude collateral inflow. Embedded knives or hematomas shouldn't be disturbed. Resuscitation by blood and IV fluids. Heparinization. Systemic heparin is recommended only in patients with isolated vascular injury presenting with ischemia. Avoided in patients with multiple injuries, especially those involving CNS, eyes, and bones. Prophylactic antibiotics should be given early. Definitive treatment time within 6 to 8 hours of the injury for limb salvage. We have methods: clean-cut arterial injuries, if the artery is contused or divided, and if the artery is found spastic. Clean-cut arterial injuries, longitudinal tears are closed with vein patch to avoid lumen narrowing. In transverse incision less than half the circumference, the injury is repaired. If more than half of the circumference is injured, complete division is performed and then end-to-end repair. In completely divided, direct end-to-end anastomosis is done. If the artery is contused or divided, damaged edges or segments excised. Patch angioplasty reconstruction with interposition graft, vein or synthetic. If the artery is found spastic, local application of papaverine is tried. Forcible dilatation using Fogarty tester or vessel dilator. If spasm still persists, excision of spastic segment with saphenous vein graft. Adjuvants, local heparin should be used routinely. Injured main veins repaired before arteries. Adequate skin covering is essential. Fasciotomy is done in late cases or muscle edema. Combined arterial and venous injuries, swelling or paralysis after revascularization. In displaced fractures, pulses frequently return after reduction within 1 hour. If pulse doesn't return within this time, artery should be explored. One should never assume before exploration that a spasm is present and that it will be relieved with time. This serious error resulted in many limb losses. If vascular injury is found, it should be repaired. Intra-arterial drug injection, etiology, drug addicts wrongly inject drugs into arteries, or wrongly injection of thiopentone into an artery during induction of anesthesia. Sites most common, brachial and radial arteries. Clinical picture, burning discomfort extending from the point of injection to tips of fingers occurs immediately after injection. This is rapidly followed by severe pain and blanching. Edema develops rapidly and may be severe. The hand is typically held in a claw-like position. Sensory loss is usually present. Whole wrist and hand might be involved, but changes are most severe in the distal digits. The fingers are usually cool and deeply cyanotic. Digital gangrene and less commonly total extremity gangrene. Signs: digital pulses are often felt and normal. Treatment: heparin at dose 10,000 international unit in IV, followed by infusion to keep the APTT at 1.5 to 2 times. In intra-arterial thiopentone injection, we shouldn't remove needle from artery before injection heparin intra-arterially. Heparin prevents thrombosis of small vessels. Dexamethasone 4 mg IV every 6 hours to decrease edema and tissue pressure elevation. Low molecular weight dextran 40 minimizes platelet aggregation. Strong analgesics, extremity elevation to reduce edema, and early passive and active exercises. Chronic limb ischemia, etiology, atherosclerosis, the most common cause, especially for more than 45 years old. If patient is less than 45 years old, we should suspect diabetic presenile atherosclerosis. Arthritis in both upper and lower limbs. Raynaud's disease, females upper limb. Berger's disease, males in the lower limb. Risk factors: non-modifiable and modifiable. Non-modifiable age, males, black race, positive family history. Modifiable, major and minor. Major, hypertension, hypercholesterolemia, smoking and diabetes. Minor, hypertriglyceridemia and obesity, sedentary life. Slowly progressive obstruction, which gives enough time for collaterals to develop and therefore gangrene doesn't occur rapidly in chronic limb ischemia. Sites adjacent to arterial bifurcations, the most common site, at the origin of major arterial branches, and at sites where artery passes beneath or through facial sling. Then we have atherosclerosis causing lower limb ischemia, affects most the aortic bifurcation, aortoiliac disease, superficial femoral artery, femoral popliteal disease, and leg arteries, tibial disease. Lesions have special distribution in descending order, affecting coronaries, then cerebrals and carotids, then arteries of lower limbs, then the renals, then superior mesenteric, then celiac arteries, and finally, the last arteries to be affected are of the lower limbs. And then pathogenesis, subintimal deposition of low-density lipoproteins, LDL fatty streaks, lead to endothelial dysfunction. Decreasing nitric oxide counteracts free oxygen radicals, releasing procoagulant and releasing inflammatory mediators, releasing angiotensin II, proliferation of smooth muscle of the media due to release of growth factors as platelet-derived growth factor and fibroblast growth factor, eventually formation of fibrous plaque, leading to arterial narrowing. Complete arterial block may occur due to thrombosis on top of atheroma or due to hemorrhage in the subintimal plaque. Clinical picture: symptoms: intermittent claudication, claudication distance, claudication time as the disease progresses, and site of pain. Intermittent claudications, cramping pain occurs on walking and relieved by rest. Early, there's pain on walking, but it can continue throughout walking. The claudication distance which the patient can walk until pain occurs and patient stops. Claudication time when the patient stops to recover. As the disease progresses, the claudication distance shortens and the claudication time increases. Site of pain depends on site of obstruction: gluteal, thigh, and cuff pain in aortic bifurcation block, cuff pain in superficial femoral block, and foot pain in distal arteries block. Mechanism: accumulation of metabolites due to muscle ischemia during walking, which are gradually washed away during rest. Rest pain: with continuous progression of the disease, the blood supply of the limb cannot even satisfy the requirements at rest, leading to ischemic neuritis, causing agonizing burning pain mainly in the foot. Pain is more severe at night when the patient sleeps, probably due to further diminution of the blood supply caused by elevation of the foot. Another factor is that the warmth of the limb during sleep increases the metabolic demands while the blood supply cannot cope with it. Warmth also induces cutaneous vasodilatation, which further deprives the nerves of their blood supply. Many of these patients spend the night sitting in a chair in an attempt to relieve the pain. Ulceration and gangrene: in severe ischemia, superficial pain erosions may occur between the toes, on the dorsum of the foot, or around the malleoli. The end stage of ischemia is dry gangrene. Impotence occurs in aortic bifurcation block due to diminished blood flow in the internal iliac arteries. Larish syndrome also includes claudication in one or both lower limbs, reduced sexual potency in males, and decreased or absent femoral pulses. Atherosclerosis symptoms: angina, cerebral stroke, or transient ischemic attacks, and postprandial abdominal pain, intestinal ischemia. And then we have general examination: signs, pulse, all accessible arteries are palpated to assess the presence of pulse, any arrhythmias, or the condition of arterial wall. A stethoscope over stenosed artery may reveal a murmur. Blood pressure should be measured. Staging of chronic limb ischemia: stage 1, 2, 3, 4. 1. Asymptomatic. 2. Intermittent claudication. 3. Rest pain. And 4. Ulceration or gangrene. Local examination: we have trophic changes, temperature changes, color changes, absence of pulses. Trophic changes: loss of skin appendages, hairs, and sebaceous and sweat glands. Skin becomes dry, nails become brittle, deformed, and lose their luster. Loss of subcutaneous fat, skin is thin and toes are tapered. Muscles become wasted and bones are osteoporotic. Ischemic ulcers may develop at the tips of the toes. Temperature changes: some degree of coldness will be detected in the ischemic limb up to level below but near that of obstruction. Color changes: pallor, cyanosis, or redness. Pallor due to decreased blood flow into the skin. Cyanosis and redness due to stagnation of the blood in dilated capillaries under the effect of accumulated vasodilator metabolites. And the color of blood is red at first, and then it becomes blue due to extraction of oxygen by the tissues. Absence of pulses: pulses distal to the site of occlusion are absent or markedly weak. Murmur may be heard over site of stenotic arterial segments. Dorsalis pedis artery is absent in 10%. Posterior tibial pulse is absent in 2%. Differential diagnosis of chronic lower limb pain: venous claudication, incompetent deep or perforating veins, neurogenic claudication due to herniated disc or spinal canal stenosis. The pain radiates from the gluteal region to the foot. The patient has to bend forwards or to lie flat on a hard matrix to relieve pain, osteoarthrosis of hip or knee joints. Then we have special tests. Tests for capillary circulation, Berger's angle, and Harvey's venous refilling time. Test for capillary circulation. If one presses over the tip of the toe, it becomes pale. Once the pressure is released, the color returns within 2 seconds. In an ischemic limb, the return of color is slow, and it's called sluggish capillary circulation. Berger's angle. Patient lies supine, limb is gradually elevated. Angle at which blanching of toes occurs is called Berger's angle. Blanching doesn't occur even when the limb is raised up to 90 degrees. The smaller the angle, the more severe the ischemia is. Harvey's venous filling time. With the patient supine, the limb is elevated to right angle until all veins are empty, then brought down to the horizontal position. Normally, veins fill in 10 to 15 seconds. In chronic ischemic, venous refilling is delayed. In chronic ischemia, venous refilling is delayed to above 30 seconds. Complications: acute ischemia. Ulceration of atheromatous plaques invites platelet aggregation, which later detach and cause distal embolism. Acute thrombosis on top of atheroma. Complete arterial block. Hemorrhage may occur under intima, leading to arterial block. Aneurysm formation. Critical limb ischemia. Persistent recurrent wrist pain. Need opiates for at least 2 weeks. Ulceration or gangrene of the foot or toes. Ankle systolic pressure less than 50 mm mercury, or toe pressure less than 30 mm mercury. Investigations: labs and imaging. Labs: blood sugar, blood picture to detect anemia and polycythemia, serum lipids or creatinine. Imaging: Doppler flow study, duplex scanning, CTA, MRA, and direct arteriography. Doppler flow study detects stenodes or occluded segments, detects collateral refilling of post-stenosed segments, measures ankle brachial index, AB index, measures segmental pressures of the different arterial segments, normal arterial flow, triphasic wave, and collateral flow leads to biphasic wave. Duplex scanning visualizes arteries and detects areas of stenosis. AB index from 1 to 1.2 is the normal, less than 0.9 ischemia, less than 0.7 severe ischemia, less than 0.3 impending gangrene. Treatment of chronic ischemia: mild or moderate claudication, conservative treatment. Severe claudication or critical ischemia, angiography. Endovascular surgery or open surgery. Conservative treatment: complete abstinence from smoking, mild exercises help open the collateral circulation, correction of anemia helps tissue oxygenation, controlling diabetes, hypertension, and hyperlipidemia. Medical treatment includes aspirin 150 mg per day, decreases platelet adhesiveness, statins to control hyperlipidemia, calcium channel blockers, cilostazol decreases platelet aggregation, increases HDL, and decreasing cholesterol and triglycerides. And then we have the surgical treatment. Indication for surgery: severe claudication interfering with the patient's work and lifestyle, critical ischemia, ischemic ulcer, wrist pain or minor gangrene to save the limb salvage surgery, or starting gangrene or pre-gangrene or resistant ulcer or long segment occluded more than 12 centimeters. Types of surgeries: endovascular surgery and open surgery. Endovascular surgery: percutaneous transluminal angioplasty, PTA. Special balloon caster is introduced percutaneously till the balloon reaches stenosed or occluded segment, then inflated, kept for about 1 minute to dilate the stenosed segment. Indications: short, less than 2 cm, or significant stenotic segments in otherwise relatively normal arteries. Success rate about 95%. Complications: hematoma, AV fistula, restenosis, or application of stent. After balloon angioplasty, stent can be inserted to prevent elastic recoil of the arterial wall and keep the lumen patent. Open surgery: thromboendarterectomy, bypass surgery. Thromboendarterectomy technique: removal of the thrombus, intima, and inner media, leaving patent lumen, which becomes rapidly endothelialized. Indications: only for limited number of patients. Applied for large artery with localized obstruction, such as localized narrowing of iliac artery. Bypass surgery more frequently performed. Idea: bypass the obstruction by inserting graft from the healthy artery above to the other healthy artery below the obstruction. Indications: big and medium-sized artery with extensive or multiple lesions. For aortoareal diseases, aortobifemoral bypass using synthetic graft, Dacron, or polytetrafluoroethylene, PTFE. For superficial femoral artery block, femoral popliteal bypass. What to do for patients who don't have good distal runoff? Lumbar sympathectomy, IV or intra-arterial prostaglandin, E1, amputation. Lumbar sympathectomy, it doesn't improve blood supply of the muscles, so it's mainly indicated when there are cutaneous ulcers or gangrene. Amputation for gangrene at a proper level or wait for separation. Indications: spreading or massive gangrene, spreading infection, severe uncontrollable pain, making the patient request the amputation. Level of amputation, it depends on blood supply enough for healing. If popliteal pulse is felt below the knee, amputation is performed, and then atherosclerosis involving femoral artery above knee amputation. The stump will be supplied by the profunda femoris. Femoral popliteal bypass, the saphenous vein is the best graft for this operation, but it has valves which allow blood to flow from below upwards only. This problem is overcome by reversed long saphenous vein graft to prevent obstruction. In situ long saphenous vein graft, valves are destroyed by valvotomy, and the vein tributaries ligated to prevent AV fistula.